ที่เรียนก็ว่านังบางตัวปัดของนั้นจะต้นชั่วโมงนังobjective เลยในตรงจากนั้นเราตาเรียนก็คือคลาสตาทำเพลนน้องลูกยังไงดูมันอยู่ไม่ควรตัวปัดของนั้นโอเคได้สิ
Okay, okay. So we warned 2 days ago that you are already participating in PPS point surveillance project, but I will still present you our idea because it might be a little bit different from yours. And some of you already saw this presentation yesterday. Sorry about this. I will try to be quick. So, as you all know, AMR, antimicrobial resistance, is a huge problem, and the most concerned countries actually are in Asia, Africa, and the Pacific. And simulation prediction models estimate that it will be even worse by 2050, and still the most worrying situation will be in Asia and Africa. So it is admitted that the current AMR crisis is the result of a multifactorial problem with over-prescription of antibiotics by medical doctors, then non-compliance with treatment guidelines, both by health professionals and by patients, with a lot of self-medication, or the presence of counterfeit or substandard molecules on the market, with over-the-counter sales, and then insufficient hygiene practices both in the hospital and in the community, and especially the lack of water sanitation, and all this, that situation is further worsened by wars, natural disasters, with population displacement, and so on. Strategies to fight AMR should be implemented at the hospital level as well as in the community, and it is especially important in the hospitals because there are a high antibiotic selection pressure in the hospitals, and then patients are more fragile than in the community because they present often with comorbidities or immunodepression status, which emphasizes the need to treat with more and more antimicrobials, and especially extended spectrum antimicrobials. And then in the hospital, contrary to the community, there is the problem of healthcare associated infections. So it is very important to try to adapt and correct antimicrobial use in hospitals and to stick to health authorities' guidelines. And for this, it is very important first to measure antimicrobial use, then to identify the potential problems associated with it, take corrective actions, and then measure again what is the effect of those corrective actions on antimicrobial use and antimicrobial resistance. So there are mainly 2 types of studies, longitudinal studies, which consist in monitoring of big groups of individuals over time, that are used to assess treatment compliance and treatment duration, and it is often used for research and benchmarking purposes. And these kind of studies are quite time-consuming and quite expensive also. And then there are the cross-sectional studies, which represent a snapshot of antimicrobial use at a given time point, and this is the case of point prevalence studies, which consist to gather information about antibiotic prescriptions in a hospital ward or hospital wards on a single day. And if you repeat these kind of studies over the years, it may give you a very good picture on antimicrobial use in hospitals over time. This is a table representing the main differences between these 2 kind of studies. The first one, the longitudinal studies, are all based essentially on drug sales data, and they estimate antimicrobial use indirectly. Also data about the volumes of antibiotic imported in the countries, and it's good starting point for countries with limited resources or limited experience in data collection. These kind of studies do not provide information on patient characteristics and why the treatment being prescribed, and it's adapted for monitoring purposes. Then point prevalence studies are based on individual data, so you get quite data about the patient itself, with the weight, the gender, the age, why he's in the hospital, why the antibiotic was prescribed, and this requires more resources to collect data. But it gives us information on both patient characteristics and treatment indication, and this is very detailed information. So this is good for monitoring and providing information for health authorities about antimicrobial stewardship policies. So the main objectives of point prevalence studies is to provide a standardized methodology to estimate antimicrobial use in hospitals, and collect data on antibiotic prescription practices by substance, by indication, depending on the diagnosis, the patient category, including nosocomial infections, and in the different specialties and wards in a hospital. This helps policymakers and health authorities to improve antimicrobial use, to improve surveillance capacities, to identify and correct bad antimicrobial prescription practices, and to evaluate the effect of corrective actions that are being undertaken. This PPS study is not an interventional one. It's just about data collection, and this data is already gathered by the hospital routinely, so there is no more data gathered than what is done normally. There is no direct contact with patients, no sampling, but still we think that it is worth to present the project to the ethics committee of the country, which is especially important for health authorities to be aware of the project ongoing, and then for publication of results if a publication is to be done in an international scientific journal. So what are the eligibility and exclusion criteria for patients in this kind of studies? So we are aiming at acute care hospitals, excluding long-term facilities like psychiatric clinics or nursing homes. We also should exclude emergency and ambulatory units, such as day surgery or dialysis units. Concerning the wards, the best to include are inpatient and acute care units. About the patients, the study includes all patients that are present in a given ward at 8 a.m. The day of the point prevalence study. It should also include patients that are discharged the day of the study but after 8 a.m. and exclude patients that are admitted the day of the study but after 8 a.m. And of course, once again, daycare patients are excluded. Concerning antibiotic therapy, it should include patients who are on ongoing antibiotic therapy at 8 a.m. The day of the study, and exclude those for whom there is antibiotic therapy which is prescribed but which will begin after 8 a.m. on the day of the study. And of course exclude patients for whom who are present at the ward at 8 a.m. but the antibiotic therapy was stopped before 8 a.m. So,
May I have a question? Related to the patient that you include in the criteria, why we choose before 8 a.m. and after the study?
I don't have a clear response to that question. It's just the recommendations of the WHO, and I think that it's in order to standardize the data gathered in different hospitals and different countries.
I think that about this 24-hour stop it, but in the guideline, if I had friend about the pseudonephritis, they attend they wait until the 48 hour after the receive about the lab result, like a culture, like like another lab, full stop. Because it's a pseudonephritis on the children, you are 48 hours. If the result of lab negative, stop in 48 hours. Yeah. Maybe it's early because the 24 days is early.
Okay.
Yeah, I don't know about the criteria of the WHO, but when I FFE, for example, so antigen, and the friend in 48 hours for stopping, yeah, antibiotic. Because if the rapid test about the about the bondlet urine, is the suspect give antibiotic.
Yes, it can revise after that, but they started before,
right.
And when they receive the lab, they can revise
Yeah.
the antibiotic prescription.
Yeah.
But it's included because it's ongoing, so it can be included. But what is in the protocol, if the patient started after the cutoff of 8, they don't include because I think they want to know before what is going on, and it's a way to standardize, as Milan mentioned, the different studies that can be done at each hospital.
So, to conduct the study, we should set up a survey team in each hospital with a team leader, and ideally this team should be multidisciplinary, including a medical doctor, a pharmacist, a nurse, a microbiologist, and health executive, for instance, for infection prevention control. And the general supervision and coordination of the team should be done by the hospital management and the medical board. So prior to the survey, the best is to contact and inform the head of the department so that the staff of the ward could prepare logistics necessary for the study. And each ward should be audited in a maximum of 1 day. And of course the size of the survey team should be adapted to the size of the wards and the number of the wards in the hospital. The impact that this kind of studies could have is to permit identification of the problems related to antimicrobial use first, and then also assess the frequency of healthcare associated infections at the hospital level, at the service level, and then permit comparisons of those factors between hospitals. Then, based on these results, implement corrective actions and continue this kind of studies in order to survey the impact of corrective actions. What is necessary to conduct this kind of study? First of all, is to train the survey team on data collection, which we provide and support. We can help you to training for data collection. And I'm ready to come back the day of the study or a couple of days before to help the survey team. Of course, if you think also that is necessary and worthwhile. In our project, data collection will be digitized, and we operate on Android tablets, which will be provided by Fundación Mérieux. There is no need of an internet connection during the day of the study. Data will be sent to the central server later. And we will try, the software is provided in English, but we will try to translate in Cambodian also. So we need a server to centralize collected data. We discussed this point a little bit yesterday. The server will be located here in Cambodia, probably at the CDC or other health authorities department. We just need to have access to this server because we work with a partner in France. It's a company called Agle, based in Paris, and this company developed the software for data collection. The system requirements for the server are not very important. We don't need a big capacity, so it should work with any kind of server. I will present you here some screenshots on the software itself. There are 3 sheets, one about the ward characteristics and the patient characteristics. So here you should, these are multi-choice lists, so you choose the ward that is being audited, the date of admission, then characteristics of the patient such as age, gender, weight, the total beds in the room, the number of rooms in the ward, and if the patient was previously admitted to another ward or not. Then we assess risk factors for hospital-acquired infections, if the patient is immunocompromised, if some invasive procedures have been done, such as catheters or intubation. Was surgery being done during the present stay or not? And you have the possibility to add multiple surgery events. And then some information which is not mandatory but could be useful on sanitation practices in the ward. Then a sheet about hospital-acquired infections itself with the precise type of the infection. Was it present or not on admission, the place of acquisition, the date symptoms of hospital-acquired infection began. Was a sample set to the microbiological lab or not? If so, what kind of sample? Was there a microorganism isolated? If so, which species? Once again, these are multiple choice lists and you choose a microorganism already in it. What are the antimicrobial susceptibility patterns of the species? Is it AMR or not, and so on. And then the third one is about the antibiotic treatment prescribed. You can add some more antibiotics in case of multi-therapy treatment. Antimicrobial name, the unit dose, the number of doses per day, the date of the first dose received, the route of administration, was there a precise diagnosis, and what was it, and where the end of the therapy is to be done. Is the treatment based on biomarker data, or was it prescribed because of prophylaxis before surgery? And so, as I said, the Foundation Merieux will provide support for data analysis, for comparison between participating hospitals, because our objective for now is to conduct a pilot study, including one hospital, and this should provide us information about some difficulties in order to take corrective actions, and then in the future include more hospitals. And finally, we provide support for writing scientific publications. And here are some papers that have been already published in other countries, and generally these papers are quite difficult to read, with a lot of tables and numbers, and some presentations could be done graphically. So as you can see here, this is from PPS study that was conducted in Lao. So you see here the different departments in the hospital, and some of them are fully compliant with antimicrobial stewardship guidelines. Some of them are somehow complying, and here some compliance, and others are not following the antimicrobial prescription guidelines at all. So these are the most worrying, where corrective actions should be undertaken. So that was all for me. Thank you for your attention.
So do you have any questions?
Yeah, our team is